All training curricula in medicine are changing in line with the standards set out in Excellence by Design, the GMC document, and surgery is no exception. This will be the biggest change in the way we train and assess since 2007. The main workplace-based assessment in the new outcomes-based curriculum will be the multiple consultant report. The MCR will provide formative feedback, but in addition will provide summative assessment for consideration by the ISCP panel. The MCR will also be integrated into the learning agreement. Clinical supervisors will meet at the midpoint and just before the end of a placement to discuss the supervision level reached by a trainee in each of the CIPs, and also whether they're developing generic professional capabilities to an appropriate level for the phase of training. If performance is beyond that expected, then this can be captured too. If a trainee has not reached supervision level 4 or 5 in a CIP, then the MCR will require trainees to identify areas most in need of development in the next 3 to 6 months of training in order to develop towards a day 1 consultant. Trainees will complete the same form as a self-assessment and identify their own supervision levels and areas for development. A trainer will meet with the trainee to discuss the MCR and the self-assessment and agree how best to develop in the areas identified. This may involve changing the emphasis of a placement slightly if one CIP seems to be falling behind the rate of development in others. In an outcomes-based curriculum which develops integrated capability in the daily tasks of the job of a consultant surgeon, the current suite of WBAs is less suited to summative assessment because they're too granular in their scope. Because of this, there will be no requirement to complete a certain number of WBAs per training year. WBAs will remain to provide additional evidence of competence by the completion of training in certain key areas of the syllabus, the critical conditions and index procedures. They can also be used by trainees to formalise and structure feedback on a particular clinical interaction or procedure if they wish. The new curriculum will allow WBAs to be mapped to critical conditions for KECs and CBDs and index procedures, DOPs and PBAs, to aid in the recording of the breadth and depth of learning. There are also changes specific to each specialty curriculum. Please consult the curriculum following for details. It's anticipated that the new curricula will be followed from August 2020. All trainees must transition to the new curriculum by August 2022. A trainee entering surgical training and starting a new curriculum from August 2020 will follow the new curriculum. A trainee entering the final year of training in their curriculum or the final year of decoupled core training can remain on the old curriculum or choose to move to the new 2020 curriculum after consultation with their training program director. Those trainees who have not reached the final year of training will move to the new curriculum as they enter their next training year. For most, this will be August or October 2020. More details on transition to new curricula can be found on the ISCP and JCST websites. So in summary, all medical curricula, including those for surgical specialties, are changing to become outcomes-based. A trainee finishes training when they're ready to be a day 1 consultant. Trainers decide when a trainee has displayed the competence required for a day 1 consultant practice in each area of the working week, the CIPs, and when this level has been reached, as well as completion of other certification requirements, ARCP 6 can be awarded and the trainee can apply to be on the specialist register. Formative feedback will improve through the multiple consultant report, and trainees will more easily be able to gain insight into their own performance and training requirements through self-assessment. More information is available on the ISCP or on our own ISCP JCST YouTube site.